Welcome to USA Tax Forms Coach. Today, we're diving into the deep end with a document that honestly gives a lot of folks a real headache, the CMS 1450, or as we all know it, the UB-04 claim form.
My promise to you in every single explainer on this channel is this. By the time this lesson ends, you will know exactly what to do next. No confusion, no guessing, no wondering if you filled something out correctly. Just clear, confident, step-by-step guidance from start to finish. That is what we do here every single day. So settle in, have your documents ready, and let us walk through today's lesson together, one step at a time. Okay, here's our game plan. We'll start by properly meeting the UB-04. Then we'll map out facility and patient demographics. After that, we're cracking the code on condition and occurrence codes, hitting the money boxes with revenue and value codes, digging into diagnoses and procedures, and finally, we'll cover how to avoid those pesky common billing errors. All right, Section 1, meet the UB-04 form. Let's understand the absolute basics. So, right off the bat, the UB-04 isn't some one-size-fits-all magic tool. It's strictly for institutional and facility billing. We're talking acute care hospitals, skilled nursing facilities, hospices, the places dealing with multi-department services, extended stays, and complex room and board charges. If you're billing for an individual private practice doc, you wouldn't touch this form. You'd use the CMS 1500 instead. Now, this is absolutely crucial. If you're actually submitting physical, paper claims, they literally must be printed on original, red, scannable forms. Seriously, do not just download a black and white copy from the internet or photocopy a blank from your desk. Why? Because the Fiscal Intermediary Shared System uses OCR, optical character recognition, to scan these. If you send in a photocopy or a misaligned printout, it triggers an immediate systematic rejection right out of the gate. Boom, denied. Let's not let that happen. Moving right along to Section 2, Facility and Patient Demographics. This is your core routing data. Which brings us directly to Form Locator 4, the Type of Bill, or TOB code. Think of this 3-digit code as the steering wheel for your entire claim. It tells the payer exactly what kind of bill they're dealing with. Digit 1 identifies your facility type, like a hospital. Digit 2 is the care type, say inpatient versus outpatient. And that third digit? That's the frequency, letting the payer know if this is an original claim, a corrected one, or a void. If you mess up this code, your claim is instantly routed to the wrong universe. Next up is Form Locator 15. This is all about the point of origin for an admission. It captures exactly where the patient came from before walking through your doors. For example, a Code 1 means they came from a non-healthcare facility, like their house or a physician's clinic. Code 4, that's a transfer from another hospital. Payers track this data like hawks, so your accuracy here is non-negotiable. And of course, on the flip side of admission, you have discharge. That's Form Locator 17. Look at these discharge status codes. Code 01 means they just went home for routine self-care. Code 03 means they transferred to a Medicare-certified skilled nursing facility. This specific box is incredibly high stakes, guys. Medicare relies heavily on this single code to calculate post-acute payments and DRG reimbursements. Get it wrong and you're leaving money on the table. All right, Section 3, Condition and Occurrence Codes. Let's talk about special circumstances. Over in Form Locators 18 through 28, you'll report your condition codes. These 2-character alphanumeric codes are your way of explaining unusual situations to the payer. Like, check out Code 44. You'd pop that in when an internal review decides an inpatient admission really needs to be bumped to outpatient status. Or Code 21, that's a really handy one. You use it when you already know Medicare won't cover a service, but you need a formal denial notice so you can turn around and bill a secondary insurer, like Medicaid. Right next door in Form Locators 31 to 36, we have our occurrence codes. Now, if condition codes explain the what, occurrence codes handle the when. They deal specifically with timelines and events that actually impact the billing. You just pair a 2-digit code with an exact date. Code 11 marks the day symptom onset began. Code 50 nails down the exact date a beneficiary became eligible for Medicaid. It basically maps out the chronological story of the patient's claim. Moving to Section 4, Revenue and Value Codes. This is all about reporting the costs. Let's kick this off with revenue codes in Form Locator 42. These 4-digit numeric codes map directly to your facility's internal cost centers. You can't just write patient stayed overnight. You have to use code 0100 for room and board. ER visit, that's 0450. These revenue codes are quite literally the backbone for payment grouping systems like DRGs. They are the language of reimbursement. Running alongside revenue, we have value codes in Form Locators 39 through 41. These are two-digit codes tied directly to specific dollar amounts or units. So this is where you'd report things like Medicare deductibles, your facility's latest semi-private room rate, or exactly how many covered benefit days the patient has used up. It neatly handles all that complex financial coordination that just doesn't fit into your standard charge lines. Okay, Section 5, Diagnosis and Procedures. Time for the clinical justification. The absolute anchor of this clinical section is Form Locator 67, the Principal Diagnosis Code. This needs to be the main ICD-10 CM code that is fundamentally responsible for the patient's admission and the services rendered. And remember, it has to be coded to its absolute highest level of specificity. No vague codes here, folks.
But let's be real. Patients rarely come in with just one isolated, simple issue. And that brings us to Form Locators 67A through Q for Other Diagnosis Codes. This is your spot to report all those relevant secondary conditions, whether they coexisted when the patient arrived or they developed during the stay. If they impacted the treatment or how long the patient stuck around, they go right here. To wrap up our tour of the form's extensive fields, let's look at Form Locator 81, famously known as the code field. This is basically your overflow valve for highly specific reporting requirements. You drop a qualifier in here to tell the payer what kind of data is coming next. So if you use the qualifier B3, you're signaling to the payer that the very next number is the provider's specific taxonomy code. Finally, Section 6, Avoiding Common Billing Errors. Let's keep those claims clean. All right, rapid fire time. Here are the top rejection triggers you absolutely need to double check before submitting. Number 1, an incorrect type of bill in Form Locator 4. Like we said, it sends the claim to the wrong system instantly. Number 2, mismatched revenue codes and HCPCS codes in Form Locators 42 and 44. Your service category and your procedure code literally must align. And number 3, missing the attending provider's NPI in Form Locator 76. You simply cannot bill institutional services without identifying the physician responsible for that care. The big takeaway here? The stakes for these 81 boxes are sky high. Because institutional claims are a tangled web, even the tiniest typo, literally one wrong digit in a discharge status code or a missing condition code, can trigger suspended claims, massively delayed reimbursements, painful compliance audits, and ultimately, a ton of lost revenue for your facility. Which leaves us with a pretty heavy question. Are mismatched revenue codes costing your facility thousands right now without you even realizing it? I highly encourage you to take the step-by-step guidance we just went through, pull up a sample of your facility's recent denials, and audit your own revenue cycle today. Because when you master these 81 boxes, you master your facility's financial health. Thanks for joining me on this explainer, and I'll catch you in the next